right, so hi everybody, welcome to Oncology Data Advisor. Today we're holding a panel discussion with our editorial board in honor of Rare Disease Day. So I'm joined by our editor-in-chief, Dr. Thomas Abrams, who is an assistant professor of medicine at Harvard Medical School and institute physician at Dana-Farber Cancer Institute, and he will be discussing rare gastrointestinal cancers. So Dr. Abrams, thanks for joining today.
Oh, it's my pleasure. This is really exciting. Thanks for having me.
Of course. We also have Maria Badillo, who is a research nurse manager in the Department of Myeloma Lymphoma at MD Anderson Cancer Center, and she'll be discussing nursing management of mantle cell lymphoma. Maria, thank you for joining as well.
Thank you, Kira, for the invitation. Glad to be here.
Great. So to start off, Dr. Abrams, would you like to tell us a little bit about the rare gastrointestinal cancers that you see in your practice?
Yeah, sure. I mean, GI cancers in general, we have so many. There's such a variety, and there's a number that are actually quite uncommon. But I think the two that really are great for this panel discussion are talking about cholangiocarcinoma and anal cancer. Both are, I wouldn't call them necessarily rare, but they're uncommon, particularly when you think about them in comparison to, say, colon cancer and pancreatic cancer, which are much, much more common. Cholangiocarcinoma affects maybe 10,000 patients a year in the United States, maybe a little more, maybe a little less. It's hard to pinpoint the number, but it's a small number in general. But there's been enormous research into molecular changes that have ushered in a whole new types of treatments that are directed towards specific mutations. We also have a new treatment for the first line treatment of metastatic cholangiocarcinoma that includes immunotherapy. So I just wanted to talk a little bit about what we can find in intrahepatic cholangiocarcinomas that can change the treatment. In anal squamous cell carcinoma, it's a pretty uncommon cancer. It's only about 5,000 to 6,000 a year, although incidence is rising, and it's an HPV, human papillomavirus related cancer. And it also has, great responses to immunotherapy. So it's an interesting cancer from a therapeutic standpoint as well. So those are the two that I'd like to talk about today. We'll talk about cholangiocarcinoma first. Cholangiocarcinoma is a disease that arises within the liver, typically in the bile ducts. And we're speaking specifically about intrahepatic cholangiocarcinoma. These are the cholangiocarcinomas that arise within the bile ducts within the liver. And it turns out that about 35% of them will have an actionable mutation or molecular abnormality that allows them to be targeted by certain drugs. The things that we find most often are IDH1 mutations, IDH2 mutations, FGFR2 fusions, and certain FGFR mutations as well. The FGFR2 fusions have a number of drugs that are now approved in the second line. Most recently, it's the covalent FGFR2 inhibitor called futibatinib that was approved, and that seems to be the best in class. It's the only disease in which futibatinib is approved. So it's a very interesting drug. And then for the first line treatment of all biliary tract cancers, we have a new regimen based on a phase 3 study that combines chemotherapy, gemcitabine and cisplatin, with a drug called durvalumab, which is an immunotherapy, a PD-L1 inhibitor. So we have this raft of new treatments that have really changed the game and made the disease a lot more manageable. It's still a very, very difficult disease to treat, and I don't want to, give the impression that it's, now something that we're, doing great with, but patients are living longer and there's a lot more optimism. And there's also the IDH1 inhibitor, ivosidenib, which is also approved after failure of gemcitabine-based therapy. Again, another targeted agent with very few side effects that can really improve patients' outcomes. So it's an exciting area, and I think cholangiocarcinoma is, we call it the GI lung cancer, because there's so many molecular targets that you can go for. Anal squamous cell carcinoma is an uncommon disease of the anal canal, and it is related about 95% of the time to the presence of human papillomavirus. Typically, patients are going to present with some bleeding, maybe a little bit of pain. And when it's localized, we treat it, interestingly enough, with just chemotherapy and radiation. And we get a cure rate of about 65 to 70% with just that, so no surgery. If there's residual disease at 6 months after completion of the chemotherapy and radiation, then a salvage surgery is indicated. And that's an APR, an abdominoperineal resection, where the entire anus and rectum have to be removed, and a patient obviously would then need to have a permanent colostomy, which is, not what we're hoping for when we treat this illness. When it's metastatic or recurrent, then we can treat with chemotherapy and also immunotherapy many times with good results. And so it is a disease in which there are increasing therapeutic avenues that we can go down, particularly, because we know that in other HPV-related cancers, immunotherapies tend to be very effective, and this is no different. So, an interesting cadre of diseases in the GI world. There are other, rare diseases that we don't see that often, but I think those are the two that I think are most interesting.
Great. So what are you most looking forward to for both of those within the next, 5 years or so as far as research?
Yeah, I mean, I think what we saw in rectal cancer that's MSI high was that you can treat an MSI high local rectal cancer with just dostarlimab, which is an immune therapy, and get an basically a 100% complete response rate, obviating the need for surgery and radiation and all these things that we do in rectal cancer. I think a similar study needs to be done in anal cancer. Now, I don't know that we'll get the same degree of response to immunotherapy, but I think it's worth looking at. And that's a study that I'm excited to participate in, and I think could really elevate how we treat this disease, and take away a lot of the morbidity that is associated with chemotherapy and radiation, while simultaneously getting an even higher cure rate. So I'm very excited about that. And then in cholangiocarcinoma, I think as we plumb the depths of the molecular targets, we're going to find that more and more patients are going to have targetable molecular abnormalities, and we're going to see more and more drugs come online that are going to really improve the outcomes for these patients. And specifically, taking these drugs that are now approved in the second line, moving them to the first line, combining them with chemotherapy, and seeing what happens. I think that's a very exciting mode of a very exciting way to treat patients, and these trials are coming online, and I'm very excited to enroll to them. So yeah, this is sort of how the field is changing, and it's a good time to be treating these illnesses.
Awesome. It's so exciting. So thank you so much for explaining all of that.
Sure.
All right, so Maria, we can transition over to you. Would you like to start off maybe telling us a little bit about what you do in your role at MD Anderson, and then we can talk about what you see with the MCL patients that you treat.
Hi, Kira. So thank you for the opportunity. I am a research nurse manager at our institution. Happy to say that today is actually my 15th year work anniversary, work with mantle cell lymphoma for that long. And so just a brief background about mantle cell lymphoma. This is a rare type of lymphoma, making it up between 6 to 7% of all non-Hodgkin lymphoma. The median age is diagnosis is usually about 70 years old, predominantly male. Typically, our patients have generalized lymphadenopathy. Some patients often have extensive involvement in their bone marrow, blood, and GI tract, particularly the colon. 40% of the patients have these symptoms, which are fever, night sweats, and weight loss. Mantle cell lymphoma is still an incurable disease. Over the 15 years that I work with our patients, there are six drugs that were approved by the FDA, which are the lenalidomide or Revlimid, the Velcade, and the BTK inhibitors, ibrutinib, acalabrutinib, zanubrutinib, and the most recent approval of pirtobrutinib. Then on July 2020, the FDA granted an accelerated approval to Tecartus, which is the CD19-directed CAR T cell.
Great, thank you. And congratulations on your 50-year anniversary.
Thank you.
Yeah, that is great. What is the role of nursing in terms of oral drug compliance for MCL patients?
So since I mentioned earlier, most of the approved drugs for MCL are oral, compliance is important, especially our patients are taking these drugs at home. Over the past couple of decades, oral chemotherapy drugs have forged a new therapeutic option, providing cancer patients with a more manageable, less invasive alternative to standard IV chemotherapy administration. Because unlike traditional infusion oncology, where doctors, nurses, pharmacists directly oversee the process, oral chemotherapy requires the patient themselves to correctly administer the drug. As nurses, it is very important that we do our due diligence in terms of educating our patients. With oral chemotherapy, the process is no longer under our direct control. When the patients are taking the drug at home, we never really know if they are taking it correctly. Non-adherence can lead to disease progression, additional physician visits, longer hospital stays, and increased mortality. Medication adherence involves a combined effort and silent understanding between healthcare providers and patients in regard to the degree of conformity in the day-to-day treatment with respect of dosing and frequency, including the duration of therapy and discontinuation. The patient's role in medication administration is significantly crucial when adherence to treatment regimens depends on proper self-management.
That's really very interesting. A lot to manage there. And now in the post-COVID era, I think that would probably even increase the amount of stuff you have to manage. Tell me how you do that.
That's correct. So during COVID, most of our patients, of course, scared to fly back to Houston. So most of our patients are coming all over United States, and some are outside United States. So nurses really have like a very big role in education, mostly managing, like I said, oral adherence and managing adverse events. Some of our patients, they're scared to fly, so we ask them to do local labs, and then they have to send it to us to check to make sure that it's within normal limits and they can proceed to the next cycle.
Do you find that the lines of communication can get a little bit difficult to manage, or do you have a way to kind of streamline that process?
In the beginning, it was, very hard. Not, like I said, most of our patients are elderly, so they're not used to a lot of remote and calling. So, but now they're very techy. They're very advanced now, and they can even text us back if we, if they need us. So.
Oh, that's terrific. That's great. It looks like we have Dr. Vaishampayan on the line, and
Great. Hi, Dr. Vaishampayan. Hope you're doing well. Would you like to introduce yourself and tell us about what you do in your role?
Hi, my name is Ulka Vaishampayan. I'm a medical oncologist at University of Michigan in Ann Arbor. My focus of both clinical practice and expertise is in clinical trials with development of novel agents. And my focus of clinical practice is within genitourinary tumors. So because of that, I have a whole slew of rare diseases that I deal with all the time. The main ones within kidney cancer, being within kidney cancer, the non-clear cell histologies are considered rare. And then there is penile cancer as well as testicular cancer, which is not all that common, but is definitely a very important problem that needs to be addressed.
So what are some of the I guess some of the biggest challenges that you see when you're treating these diseases since they're so rare? And then also what's some of, the exciting research that you've seen lately in them?
So most of the time, our biggest sort of priority is to practice evidence-based medicine. Unfortunately, in rare diseases, there are not those large trials that will guide us and give us, adequate information to make those treatment decisions. So that, I think, is the biggest challenge in these rare diseases. Obviously, if we can find a very crucial genetic abnormality that or a mutation that will give us an inkling as to treatment, for example, the TSC1 mutation predicts for a huge sensitivity to mTOR inhibitors in some of the chromophobe and non-clear cell histologies within kidney cancer. So we're making inroads into identifying some of the unique features of each of these tumors that are allowing us to personalize the therapy. But clearly, a number of these patients have no exact targets identified. So we are treating them with from studies and extrapolating from patients with clear cell kidney cancer, which is the more common variety frequently. The other challenge, of course, is in terms of prediction of prognosis and discussion with patients about what kind of treatments to pursue and what to expect from their disease.
How do you go about talking to a patient who has a rare form of kidney cancer, say medullary kidney cancer, and what to tell them about prognosis? You mentioned that it's difficult to kind of point to any specific phase 3 trial or really any retrospective data. And so that's always a difficult position to be put in.
Yeah, I think you bring up one of the most challenging histologies in rare diseases, which is medullary carcinoma. It is associated with sickle cell disease. It usually affects the very young patients population. So because of that, and disproportionately affects African Americans because of the sickle cell trait is more common in those patients. This is a very aggressive disease that very rapidly spreads and metastasizes. So we frequently have to have the discussion that this is an incurable, terminal malignancy, and we are still trying to feel our way as to which treatments really work. So we do upfront chemotherapy, which can give us responses for some time, but for the most part, almost everyone relapses or progresses, even though they have an initial response. If you can do surgical removal, the disease is rarely confined to the kidney. Most of the time we find it when it's metastatic. But if it is truly confined to the kidney, then surgical management is key for these patients. And I think overall, it's a tough discussion because there isn't enough focus. Now there are some studies that are looking at specific targets in this disease and trying to develop targeted therapies. But we have a long way to go in this cancer.
Do we know why there's this relationship with sickle cell trait, or is that sort of unknown?
I don't know that we know the exact pathophysiology, but it does appear to be that sickle cell trait is frequently associated with a lot of collecting system of the kidney as abnormalities. So, whether that chronic irritation has anything to do with it is probably, a simplistic view to say that that causes the malignancy or at least triggers something.
Yeah, I was on the inpatient service a while ago and
Yeah.
the inpatient with this, and it was just shocking because I'd seen her a couple of months prior.
Yeah.
And then she came back on service and the deterioration was just so rapid and she ended up having a massive PE and dying on service. It was just horrible, just terrible.
Yeah, no, it definitely stays with you, and we just need to turn that emotion around and really focus on research in this disease, because I think it is attainable. It just, these rare diseases, there aren't enough patients, so it's hard to get the focus on them to do specific research.
Thank you, Ulka. That was terrific.
Yeah.
And thank you, Maria. I think this was really, important to shed light on these rare diseases and know that there's research. We're trying to, move the needle and instead of just sort of treating as if this were some more common disease, but that is sort of, what we do in a lot of these diseases, but trying to find the needle in the haystack is really the key.
Yes.
Yeah, I think we have made inroads in a lot of these diseases.
Yeah.
Yes. Well, thank you all so much for sharing all of us. It was, great to hear about all the new research and what to look forward to in the future.
I will just make a pitch that, clinical trials are the way we make advances. So definitely encouraging your patients to consider those as the most cutting edge treatment, especially for rare diseases, is very important.
I 100% agree. Couldn't agree more. Yep, absolutely.
Same here.
Thank you.
Absolutely. Well, thank you all again. And thanks to everybody for watching today.
Thank you.
Thank you.
Bye.